Okay, I guess we'll get started. Again, thanks everyone for coming on. We'll get this thing recorded so that those who aren't able to hear it can hear it at a later time. My name is Peter Antevy, and we're about to hop on a plane to Dallas, but we wanted to get this webinar out, and really wanted to get some of your input at the end of this. Obviously, as we go through this process, we're learning a lot of new things about pediatric medication that we never knew before, mainly because of the fact that first of all, there are new medications, but secondly, the volumes are so small and so tiny that actually my screen wasn't showing. Here it goes. The volumes are so small that the question then becomes, well, how do you administer a volume of 0.04 mLs? And how do you not make the mistake of giving 4 instead of 0.04? And how the heck do you give 0.04 anyway? And so I wanted to address this. This is not a talk about pain scales and all that type of thing. This is kind of a more direct kind of talk regarding some of the EMS issues as I see it, and hopefully I'd love to get your input for those of you, because everyone on the call is using our system. I really wanted to get input from you guys. So just to start off, this is not a comprehensive pain talk by any means, and I did that on purpose because people have sent me, or I've seen these pain talks that are painful, and I didn't want you to go through that. And so I just wanted to get really a real discussion about EMS, the realities regarding pain control, why pain medication is not administered to children and sometimes even in adults in agencies, the past, present, and future of pain control in children. And I think over the last couple of years we've seen some new names enter the mix, and some old names are kind of exiting stage left. We'll talk about some of the medications, and then at the end we'll show you some of the tech that some of you have seen already, and then I'd like to open it up for your comments, your feedback, and your input. Obviously, I don't come to you as someone who knows everything by any means. I'm on the other end of the spectrum. We just maybe think about it differently from where we sit, right? So just to start off, think of your agency, and let's say I give you this simple case of a 5-year-old kid at a playground who fell, has an obvious deformity. The kid is screaming. What would your paramedics or your colleagues do today for that 5-year-old? And again, is that paramedic specific? Is it shift specific? Is it agency specific? And I will tell you that I have the great pleasure of working with over 2,000 paramedics, and still have no idea, or I'm trying to figure out what makes someone say, let's stop, take a deep breath, and treat this child before we move them. Let's obviously do a good history and physical examination, but this is just an intro to asking you the question, do all of your medics, or if you're a paramedic on this call, do you treat pain the same way every time as your colleagues do, or not? And I think that's the so Keith, you're typing in here, right? So 2 mics per kilo intranasal, and immobilize and elevate, yes. But will all of your paramedics, Keith, do the same thing? Really, that's my question. Or will they get to the back of the truck before they do it? Will they administer medications after they move the child, or before, or not? And so really those are the questions that I struggle with as a medical director, as a physician in the emergency department. I hate to say this, but some of my colleagues, when they're working on a shift, I know it because I hear kids screaming, they're getting abscesses opened, or LPs are being done on infants without lidocaine. And so really that's the question. What is it that drives the use of pain control in children in the pre-hospital arena? And I'll give you my opinions, and I'd love to hear yours at the very end. And so again, this is the obvious one, right? So what are the realities really of why pain medications are not given? And just like Keith did, if you guys are, I know that you guys are all muted, but feel free to type in either in the chat or in the question bar your comments that I can address as I'm talking here. But um, why aren't we giving pain control? So do you QA all of your calls that if a pain scale of greater than 5 is documented and a pain medication is not administered, are you QAing that from your level or not? And I guess we should start even with earlier than that. Are pain scores even being documented for our patients? And that's really probably the first step to doing to figuring out exactly what the problem is at our agency. I did want to make a couple of things that you've seen before, but we finally have the published data to show this. But we all know now that there is no pain control medication listed even on the Broslo tape. So the fentanyl dose is not the pain dose; it's the pre-medication dose. And so I gather that if you're an agency who still uses the Broslo tape and you have to remember the dose, which again is pretty easy to remember, but then you have to figure out the kid's weight because this tape is not going to help you figure out a pain dose. The fentanyl dose is incorrect, and there is no morphine on here, and the ketamine dose is not a pain dose clearly as well, and there is no dilaudid on here. And so I surmise that the reason pain control in pediatrics isn't used in general is because the information is not readily available to the parent. That's step number one. So that's that. We also found this paper, an abstract that was just presented in Boston at AAP in October, which also showed here that exactly what we've been saying all along, which is finally coming to fruition, that even in the evidence-based guidelines, there's 7 of those that most of the medications are not listed at all. And then when you look at the incorrectly listed ones, fentanyl is there, and then morphine is clearly missing from there. So we have, again, a very big gap of information for pediatrics in general, whereas for the adults, it's pretty straightforward. And this is a shameless plug for the paper that was just published. This is an unfunded study done in Denver comparing our system to the Broslo, and showed a significant difference in dextrose and also in provider satisfaction. Okay, back to pain control. So what are the realities? And again, these are the things that we hear all the time, and you probably hear either the same or different. It's a kid, I couldn't get a line, we were close to the ED. So my question for you on this one, and again, I'd love to hear your in a bit here, or actually, you know what we ought to do? If you have a comment as I'm talking that you want to, you can just kind of click on the hand raise button. There's a little hand raise button, and I'll just unmute you. I think that's what I would like to do. Okay, so Jim, I'm going to bring you in here because there's not many folks on the whole call, so let's just unmute you, Jim. Go ahead.
I think that one of the problems for us is just a basic misunderstanding about the physiological effects of untreated pain in children. Mm-hmm. And I think if pre-hospital providers had a better understanding of the effect of untreated pain, they might be more likely to give the appropriate pain relief at the time, whether that's a drug or a distraction or something else.
Okay, but let me. I mean, that could be true, but I have a feeling that if you explain it to folks, the physiology behind it and how it alters them and so forth, I still have a feeling that there's other roadblocks that are in the way. And one of them that I have on the screen, and again, I'm interested to hear what people have to say about this, is that, you know, I have a feeling that depending on your proximity to the closest emergency department, will probably have an effect on your thought process. And I hate to say that's true.
It is true.
But how? Right. And so how do we go against that, and how do we change it? Because I hate that line. Right. We're close to the ED, and therefore the kid's pain over the next 5 minutes doesn't really matter to me. Right. Until it's your own kid. So so thanks for that. And yeah, Keith, I want to bring Keith in here. Hold on. Let me unmute Keith. Keith, go ahead. You're unmuted. I want to hear what you have to say.
Thanks, Peter. You know what? that's probably the number one that I've got with our pediatric dosing. And what I had to do is actually go into our ED data and show them just how long it takes the patient pain meds after arrival. And
do you have that data?
I do.
What did you find? What did you find?
45 minutes.
Wow, 45 minutes on average. Do you know what the N was? I mean, how many patients did you look at?
This was all this was all patients, so both adults and peds, because we don't really have a primary peds ER.
Right, but how many? How many in total? How many patients in total?
This was 1,500 patients.
Wow.
Yeah, for 1 year, 3 hospitals of just that we transported with who had gotten pre-hospital pain meds it was for trauma. We didn't do it for we didn't look at the belly pains and other stuff because we know that's more of a workup. But obvious trauma, and it was 45 minutes.
Wow. Okay. Well, is that published, or are you putting that together into an abstract?
I would love to. I think I'll do it because it just came out of our QA data. But
that's actually a wonderful piece of information that I'm going to kind of put in my back pocket and use, because I think that's something that would make me say, as a paramedic, hey, you know what? 45 minutes, that's a long time. And there are ED studies, by the way, that show the same thing, that show that from the time the patient hits the door until they get pain control often is a significant amount of time. And it's probably also within that same 30 to 45 minute window. Right. Okay. That's cool. That's awesome. And again, if anybody else wants to pop in, I'll just unmute you. So here's another one. And I have a feeling this one was a big one, which I didn't know the dose. That's a big one. Afraid I'd give too much. And this goes to a little bit of what Jim Levi was saying a minute ago, that in pediatrics, especially with the infant, because of how their total body water is significantly greater than an older child, the amount of albumin that they have, and so forth, really, and their glomerular filtration rate is decreased, I should say, and therefore the actual dosages in infants, really we have to pay a little bit more attention to that. But again, with the fact that we have reversals at our at hand, this shouldn't be the reason anymore. And again, I'm curious as we move forward and as we learn more about this, exactly what are people saying at your department if they're really telling you the truth. And so, but I still think that there's a number one reason, and I haven't been able to prove this just yet, but this is something that happens at my department, and I hate to say that it does, but once I started to trace the steps from the very start as to exactly what happens when someone says, let's give a dose of fentanyl or morphine or what have you, the steps that I've kind of written down here, I'm curious to see what y'all have to say on this one. So, and again, please find out what this is at your shop, because I'm sure that it's different than it is at mine. But we have to go, first of all, retrieve the medication, which is in a locked box, and we have a whole system of securities on our box, with a key and so forth. There's paperwork that we have to fill out, and then we have to then figure out what to do with the waste for these medications. And I don't know about you all, but ever since we went to fentanyl, I'm always very worried about diversion more so. And maybe this is not a good, maybe I'm not thinking about it correctly, but I am worried about diversion more so with fentanyl. That we have a very, very specific process by which they have to return the vial. The cartridge jet is how we carry it, and then so that's a whole process they have to go through. And then what I learned here is that how do we restock the vehicle? So if it's 2 o'clock in the morning and you've given away your last dose of fentanyl, now what do you have to do? And for the most part, you have to wake up the battalion in my shop, and the battalion has to go and get you more. And so I've polled some of my folks, and they kind of regrettably and truthfully told me that, hey, sometimes if it's in the middle of the night, they'll try to kind of hang on to their narcotics just so that they don't have to bother anybody in the middle of the night. And so, is the process, and again, we have all the DEA issues and so forth that we're all dealing with around the country, and I really worry about diversion in a serious way. But I do worry that the process changes the way that our paramedics deal with it. I'm curious as to if anyone who's on the call now wants to jump in. If you have a comment on this particular part, because I'm curious to see how other people around the country are dealing with the process of pain control as it relates to their EMS system. So if you do have a comment, just raise your hand and I'll unmute you. And if not, then I'll keep going on. Okay. So here's the policy at my department, and it's an 11-page policy. This is one of my departments, and it's an 11-page policy, and it's the do's and the don'ts. And just taking along one read through this, and you realize how difficult, or not how difficult, but how careful we are with narcotics, and rightfully so. But at the end of the day, I wonder if that affects any of us. So I'm not sure if there's a way to quantify this exact behavior, but I do have a sense that this is one of the problems. Meaningful use, I think, is something that we all need to be aware of. I just was at a talk recently with Alex Garza, who now works with First Watch, and he worked with HHS and in Washington, and he gave a very nice talk about meaningful use in hospitals. And then he talked about meaningful use in EMS, and that's coming our way. And all of you now, I'm sure, use electronic medical records, and those medical records are going to be the foundation by which we're going to then have to prove to somebody at some time what our outcomes are, and are we treating pain correctly. And so this is kind of what I alluded to earlier, is that there is going to be a day coming very soon when, if we document a certain pain score, then we're going to have to say, did we treat those patients? And if we do, we get reimbursed for that specific patient more so than if we do not treat a pain score of a number or greater. And again, I'm just kind of giving you like the general schematic. For example, let's say that patients who are in cardiac arrest, for example, are not getting the same outcomes as a national benchmark, or let's say that you're not providing PICU CPR. Can they come back and say to us, as an agency, your reimbursement is on a sliding scale? And that's what they're doing in hospitals, and it's surely what they're going to do in EMS. The foundation is set up to do that. I know that there's the analytics with some of these EPCRs is very robust. Software companies like First Watch, First Pass are going to be ones that come to the forefront. ESO is another company doing the same thing to help you analyze your data, because that's going to be it's going to be a requirement and not a recommendation anymore. And so, obviously, regarding pain control in children, we always want to go through a history and physical examination. That goes without saying. Keith, you alluded to a minute ago trauma versus belly pain. Jim, you alluded to the physiologic issues that occur with pain in children. But the question I pose to you is the child who's screaming, are they in pain? And then the child who's not screaming, does that mean that they're not in pain? So here's a picture of just a brat who doesn't have any pain, just screaming his head off. And then here's a picture of a sweet little girl who's got sickle cell, who has a pain of 10 out of 10, and her heart rate is normal, and her blood pressure is normal, but she's in significant amount of pain. And we often see that in the emergency department. And we do see a lot of providers who do fail this test of this kid cannot be in pain because they're not acting like they're in pain. And so part of the issue, again, that I see with pediatric pain. If it's an obvious one, like I showed you earlier, it's an easy one. But then again, we had a kid recently come to the ED who was writhing in pain. I mean, this was a 5-year-old kid who couldn't even stay on the bed, and there was no IV placed, there was no fentanyl given intranasally or what have you. And this girl was having ischemic bowel pain because she was having a volvulus, which is, as you know, probably the most painful type of pain, which is ischemic pain. And so that's an issue. Keith, I see your hands raised. Let me unmute you. You're on. Go, Keith.
Yeah, and I know we didn't want to get into pain scales, but for to help detect the young girl who doesn't have the overt findings, have you found one pain scale better than the other? I've been looking at pieces of hurt. If you're familiar with that, where you give the little poke.
Which was it?
Pieces of hurt. You give them like poker chips or Chinese checker chips, and have them stack them in a stack based on how bad they hurt.
Really? And has that been validated? I haven't heard of pieces of hurt.
Yeah, no. It's right up there. I mean, apparently, I'll send you a couple of resources. I was looking at it, and it's very interesting, kind of a psychomotor, because you get that patient who's really not, it's kind of in that pre-verbal, totally, you know, and they can't really, the analog scale doesn't work, and you give them five checkers, and they seem to figure out how to quantify that.
Really? Oh, that's and you know what? If that's been validated, I'd be interested in that. Also, there's also something that that someone just created at one of these, like, hacking pediatric events, they call it, where they actually gave the kid a squeezy ball, and inside the squeeze ball there was a Wi-Fi connection to the nursing station, and the harder that they squeezed that ball, then the pain scale, the pain score went up a little higher. And again, there's probably an age by which, because I'm sure if you gave it to my 3-year-old, he'll just squeeze that crap out of it. I'm sure. But yeah. So I think that there are better ways. I don't think that the scales that we all use, I hate to say it, I think that I'm not sure how much value sometimes I can put into those. When you walk in and you ask a kid what's your pain score, you show them a picture. It is helpful because it gives you a baseline, but then I think for me it helps how far they've moved from that baseline, because you can have a kid who says my pain scale is a 2, and that same pain could be an 8 for somebody else, but now their 2 went to a 10, and that means more to me than anything else. So that's interesting. I do think we have to figure out the pain evaluation better in EMS. I just think evaluation in EMS in general probably needs to be buffed up a little bit. I'm going to unmute Jim again. Jim, can you hear us? You're on.
Yes, I was just going to mention that I've been, in the presentations I've done on pediatric pain management, the pieces of hurt that Keith referenced seemed like a great tool. To be honest, I don't know if our pain and palliative care clinic uses it, but the research I've seen on it is quite good in terms of its validation. So I'll send you some information on it as well. Because
now, the question
that it's a hands-on thing, which I think engages the pediatric patient in a way that the pain scales don't.
Right. Well, you know what? This is interesting because I haven't seen this thing, but I also want to see if, for speaking of strictly of EMS, in other words, we need to figure out a way to have our providers get to the scene and evaluate pain in a way that's meaningful to them, and that will stop them and say, you know what, we're going to stop right here. I mean, we're talking about the obvious ones where the kid's ankle is at a 90-degree ankle. That's an easy one, right? Well, maybe not. But the ones that I'm talking about are, is there a way for our paramedics to get to the scene with a kid who has abdominal pain or sickle cell pain, and do a quick assessment, get the pain scale, and say, this is a patient who needs pain control based on whatever formula or whatever algorithm we've given them. And so, but it has to be something that's quick, that's that's obviously validated, but that's accurate, but that's EMS friendly. And again, maybe the FACES scale would work. But I will tell you that moving forward, for all of us on this phone call, that we need to emphasize that our paramedics evaluate pain and actually score the pain and document that score, because we're going to be forced to do that. And then anyway, I think it's a good practice. I will bet you that if any of us went to our own systems and did a search for trauma and then looked for a pain score, especially in pediatrics, you're probably not going to find it unless you actually push for it and you QA that. And again, if it depends on what kind of QA you have at your facility or at your agency, whether it's an automated QA or you have to go looking for that. It's obviously easier if it's on a dashboard for you. Okay, moving on. So I did want to move into the next section here, which was just talking about the options that we all have. Now, obviously, what's listed at the top, the NSAIDs and acetaminophen, there are some agencies who actually are using oral Tylenol, Motrin on their vehicles, but those are very few and far between. Toradol obviously is used more so in the on the hospital side. It does have a lot of contraindications, and I think there aren't that many EMS agencies using Toradol in general. So I think that for us in EMS, unless someone on the call feels differently, I think that this top section is not really where we live for the most part. Obviously, a family member can give and administer something, but for the most part, it's not. There, James. Okay. For the most part, this is not an us thing. Let's move into the narcotics and the dissociative anesthetics. So, morphine, fentanyl, and Dilaudid. And I'm curious to see what not just the folks who are on the call today using. If you wouldn't mind. For those of you who are able to just type it into the chat to everyone or just to me personally, which medication you're using, just so I can kind of get an idea. And then I'll talk about these three things individually, some of the drawbacks that I see, and then we'll talk about ketamine. And then I put nitrous as an other, and I guess we can discuss that at the very end. So these are the ones that I really wanted to focus on here. So the way that I wanted to think about pediatric pain control differently than maybe you've thought about it, and it's only because of the experience that I've had, is if we focus on the final volume, then I think we can make a better judgment on how to train people, make a better judgment on what our protocols would look like, make a better training or a judgment on what our training would look like. And so what I'm going to do is kind of just go through concentrations of medications, dosages of medications, and then the route and how that affects, as much as we don't think so, these three things on the screen here are different everywhere. I'll bet you everyone on this call uses a different mechanism, if you will, or a different way of sorry about that, a different way of actually carrying their drug. The dose is different, the route is different, and so that's what I wanted to talk about, and then show you the volumes. And then I think there's a whole nother problem in pediatric pain control that really no one's ever discussed. We've just said, here's your fentanyl, give it, and then we haven't talked about anything else. So Keith, you say here fentanyl for trauma, morphine for abdominal pain, and Nate says MAD with fentanyl, so the intranasal device. Good. Okay, so we're going to talk about both of those medications in a little bit too. So here's an example of what I'm talking about. Morphine in EMS, typically everyone here, I would assume if you're working in the EMS department, you're carrying a 10 milligram per ml. The dose per kilo is typically 0.1 milligrams per kilogram, and you're more than likely going to be giving that an IV or let's say even IM. So let's do the math real quick. A 1-year-old is 10 kilograms. 10 times 0.1 is 1 milligram. And then you go 1 milligram divided by 10 milligrams per ml, and you get a volume of 0.1 ml. And so that issue right here is a big issue. Number one, because is this the best concentration to use for pediatrics? What do the pediatric people use? And I know I have Nate on the line, I have Jim on the line, who are pediatric people like myself, and I've done enough in-services with our system to understand that when people see 0.1 ml, oftentimes they'll just give 1 just by accident. And so is this concentration the correct concentration to use when we're dealing with pediatric patients? That's my question to you. I don't have an answer for it, but I will. That's my question. What happens in the pediatric ER? And so if you come to my pediatric ER, well, all of a sudden the morphine concentration is very different. There's 2 milligrams per ml. We have the 4 milligrams per ml. And now you do the math, and this is a little bit easier to swallow for as far as a dose is concerned. If you do the math and go all the way through again, instead of 1 divided by 10, you're 1 divided by 2, and that gives you a dose of 0.5 ml. And so just consider that for morphine. And then I want you to consider here, these are all the concentrations that you may find. And so if you look at this list, and I'm asking you kind of individually and personally, which of these concentrations do you carry today, if you carry any of these drugs? So if you're an EMSer, more than likely you have this one. If the beauty of fentanyl is that it only comes as this one, 15-1 or 102, same thing. What about dilaudid hydromorphone? It comes 10-1, 4-1, 2-1. And so which of these do you carry? Ketamine, and this is the biggie, right, that we all carry nowadays, but what people don't realize is that the 101 is, obviously they realize it's the most concentrated form, but then there's some dangers to that. It also comes as 15-1, and then what you'd see in the pediatric ER is the 10-1. And so whenever you see the pediatric folks using one thing and then the adult folks using another thing, the first instinct is to say, all right, well, let's just use the same thing for pediatrics. And in EMS, we're more than likely not going to stock, not more than likely, no, we're not going to stock 2 different concentrations of morphine. We're not going to stock 2 different concentrations of dilaudid, and some people are starting to do this, but this is the one where if ketamine is your drug of the future, then this is a big issue, which I'm going to highlight here in a little bit. Now let's start looking at the dosages, right? So the pain dose IV for morphine, for fentanyl, for dilaudid, and for ketamine. Look at these numbers. They're all fractions for the most part, except the fentanyl here. Some people go up to 2 mics per kilo for fentanyl IV, which is fine. But again, you have a range. Try and do the math on this one. Dilaudid 0.015 milligrams per kilogram. And let's say the kid weighs 4 kilos, or let's say the kid weighs 15 kilos. All of a sudden you're doing a math problem that's very difficult to do, and you're getting a volume that's really tiny. The ketamine pain dose is it's about 0.25 milligrams per kilogram. Some people go lower, some people go higher. I think that's a pretty good number right here. And then when you go to IM and IN, the numbers start to change a little bit. And then when you go for sedation, so a different indication for the same exact drug, now you have a whole different regimen, and the numbers vary based on IM, IN, and IV for ketamine. We know that. So what I was trying to point out on this particular slide is that depending on your medical director, and depending on the concentration that you carry, all of a sudden the numbers are very different, and not only are they very different, but they're very small. And so think of it from the field provider perspective, how difficult these numbers become when you're looking at volumes and you're trying to give it through either a small IV or even intranasally, right? So I'll show you some numbers in a little bit, and I'll ask you, how would you advise giving some of these medications like fentanyl intranasally when the dose total is 0.1 ml, 0.1 ml total? And so that's really something to think about. And so route does matter, because what is the dead space for intranasal medication? what is the amount of volume? And no one talks about this stuff, right? What is the dead space for the MAD device? And the number is 0.1 ml. So if the amount of volume you're giving total is less than the dead space total, then nothing's going to come out. And so how do we adjust for that in the pediatric world? And if you ask 5 different people how they would approach that, you're going to get 5 different answers. And so I guess part of my mission is to get all of us on the same page together and say, hey, well, what my best practice is this, and it works. And then we can start to tell, and educate the masses of the right way of doing things, because I have a sense that everyone's doing it differently. The IM route, obviously, there's a lot less use of IM medications in general in EMS thanks to the MAD device, and then the same can be said for IV pain control as well. And then obviously there's a big issue with fentanyl and ketamine via the IV route that we'll talk about. Actually, let's just talk about it right now. So with fentanyl, there are case reports when given IV rapidly that there is a frozen chest, rigid chest syndrome, and essentially that's a scary moment. That's kind of like when your heart kind of goes up to into your throat. It never happened to me, thankfully, but again, if the volume of fentanyl is so small that your only choice is to just get it into the hub and then flush it right behind, you're basically bolusing that entire thing in very quickly, rather than maybe diluting it and then administering it slowly. And so that's an issue for me for fentanyl going through the IV. And then ketamine has another side effect, which we'll talk about in a minute, and I'll show you some images for that. For those of you who have morphine and haven't converted away from morphine yet, I find this graph probably the most interesting. And when I rolled out, when I kind of got rid of morphine altogether, this was the best, easiest way for me to convince my troops that that morphine maybe didn't have a place in EMS for my specific department. And it's because when you look at the pain score, and you can see the morphine here is in this pinkish purple color, you can see here that it takes about 25 minutes until your pain score goes down to a 3 from a 7. And for most of us, we're in the ED by then, and the patient's still in pain. And right when the doctor walks in the room, the patient says, I feel so much better. And they give all the credit to the doctor. And so most of us in EMS, unfortunately, don't have the ability to watch patients improve with their pain with morphine so much so as to do with fentanyl, which is here in the blue, showing that the fentanyl, because of how it's metabolized, and it crosses the blood-brain barrier rapidly, really without being metabolized, it just can cross right over, and the effect is really not immediate, but it's, in other words, any EMS provider will notice will know what the fentanyl look is, but when you ask them about morphine, they won't tell you the same thing. And so I think that's really an issue. Now ketamine sits all the way here somewhere, right? So ketamine, you'll see the response very, very rapidly, probably in under a minute. And so I think that's another big question is where does ketamine fit into this whole scheme of things? And I think that the biggest problem with ketamine, as you'll see in a minute, is the volume and the dose. So for fentanyl, obviously, everybody is different. Again, there are people who have a broader range for IV dosing. Obviously, we recommend going up higher on the intranasal dosing, or if you're a department that wants to stick to a lower intranasal dose but allow a second intranasal dose, that's fine. But please be cognizant of the fact in pediatrics, not all the medicine is coming out of that device. Dilaudid is again something that I don't currently use, but there are agencies out there who are using our system that have Dilaudid on their trucks, and you can see here that Dilaudid comes as 2 milligrams per ml, 10 milligrams per ml, and again here's another 10 in 1. It also comes as 4 in 1, and try and do this math on any young patient, and it's, for me, a scary proposition if you're having to do the math at all. If you know the math and the math is given to you and you're giving a volume, the volumes are very, very small. And with dilaudid specifically, it's very potent, and it will cause respiratory depression and a heartbeat if you give an overdose. Ketamine. So my favorite drug of all time, obviously, is ketamine, but I've struggled with the ketamine in pediatric for pain, and the reason is purely the number and the volume. And we carry 101. That's what I carry at my department, and that's what I'm sure most people here carry. Great for IM, great for IN, but here are some problems with it. Is that you should never, ever give the ketamine, the concentrated form, intravenously at the 101 concentration, because it's just the risk of laryngospasm is, again, it's not so tremendous of a risk, obviously, but it's there. And if ketamine is not given over 60 seconds, and again, in pediatrics, we use ketamine. We've been using ketamine for 15 years. We have a lot of good experience in pediatrics with it. And there's one physician I work with who's had like 4 cases of laryngospasm because she just slams in the ketamine every time until we realized that's what she was doing. We just told her to just go slow, and it shouldn't happen. So, but if you're giving it at 101, this laryngospasm can happen. Just a little side note on the laryngospasm with ketamine is that there's the Larson's maneuver, which is in what the there's a notch right at the base of your skull. If you put your finger right kind of at the base of your skull, and the back of your finger is the mastoid process, and anteriorly will be your condyle. If you put 2 fingers, one on each side, and you just kind of push together, and that jaw will move forward, that takes care of laryngospasm secondary to ketamine. And I've seen that work several times. And here's the maneuver. It's almost like excuse me, a jaw thrust, but really getting your finger into that notch and pushing really hard and relieving that laryngospasm. So this is something that I've kind of educated all of my field providers on in the event that it happens. Back there, yeah. So that's that. Let's talk about ketamine, the pain dose of ketamine of 0.25 milligrams per kilogram, which is a lot lower. So my question to you is, when would you dilute this? So, and again, I don't have the right answer here, and I'll show you a little video that I just made before coming on today, is do you, question A, do you dilute first, meaning do you tell your paramedic, here's 100 milligrams per ml, and there's 5 mLs of this, I want you to convert it first into 10 ml, and then recalculate what the volume would be, and then give the volume, which is what a pharmacist would do. Or do you say, here's the volume of 101, let's say it's 0.1 ml, and then after you have the 0.1 ml, you add some saline in there to dilute it to a volume that can then be given over 60 seconds. And again, I haven't heard any good answers on this one. I think if anyone on the call has any great thoughts about this, I'd love to hear it. But I'll tell you, my thoughts is take the volume of what you have. So the 101, say take the 0.1 as the volume that's listed, and then dilute it with X number of amount of saline. Again, it probably doesn't matter how much, but as long as it's a number that you can titrate in, not titrate is not the right word, but just give a slow IV push over 60 seconds rather than slamming it in and then slamming it home with a flush right afterwards. Because if you leave that 0.1 ml in the hub, it never got to the IV anyway, and then you slam 10 cc's of saline afterwards, then that basically is not doing that patient any good. And so this is what we use in the ED. This picture didn't come out so good, sorry. But this is the 10 milligrams per ml that we use ED. And even at the 10 milligrams per ml dose, if you multiply out by 0.25 mg per kilogram, the volume of ketamine for a pediatric patient for pain is super low. And so the good thing is that it's very difficult to overdose on ketamine. The concern I have is that people are going to screw up the dosages and they're going to use the wrong concentration. So I think we have a lot of work to do on the pediatric side of ketamine as it relates to all uses of ketamine in pediatric patients, and working within the system that currently is used by EMS, which is to carry one concentration. So if you come to my pediatric ED, this is the only type of ketamine you'll find, because we rarely use IM dosing. It's only pretty much IV for our sedations. And so this is kind of my favorite technique here to dilute things. And again, basically, the other interesting part about EMS, and specifically with a fire-based service like I work with, is that they hate the three-way stopcock. And I've been told it's because this three-way stopcock is it goes opposite to what a typical fire hose thing would be. So it's exactly opposite. So firefighters apparently don't like this thing. So there's actually a firefighter in California who made it so it looks exactly like what they would be comfortable with. And then there's also a two-way stopcock. So either way, here's the setup that I am proposing to you guys today. Let me show you a little video. So you would hook up, let's say you would get that dose, and then you would just take your saline flush. Obviously, there's a little air bubble in there, but you would then use that. And then the same thing, I did a 1 cc syringe, so take a look at this video. I'm not sure that the video is coming across so well, but essentially there's a 1 cc syringe, and then you just attach it. So let's say that's 0.1 cc's of ketamine, and you just added in 0.9 mLs of saline, and now you've diluted it by tenfold. Now you have 10 milligrams per ml of ketamine instead of 100 milligrams per ml of ketamine. And so I'd love to hear your thoughts on this, either verbally in a little bit, we're almost done, or at the end. What I went ahead and did, just to show you some demonstration of actual dosages, I went into our system and I only input pain dosages. And I did a preemie, I did a 1-year-old, I did a 5 and a 9, and then I did adult. And the reason I did that is because I wanted to show you all the medications we just spoke about, and then I wanted to show you the numbers behind those medications. And I mean, look at this. It's just, for a preemie, obviously a 2-kilo kid, are you going to be giving pain control? Very unlikely. So let's move to the 1-year-old. Fentanyl intranasal, 0.4. Fentanyl IV, 0.2. Dilaudid, 0.08. Ketamine for pain. And this is the 10 milligram. This is what we use in the pediatric ER, is 0.25. But if you were to use ketamine for pain in using what you have currently, it's 0.03. 0.03. Morphine at the concentrations we carry is 0.1. At the concentration we use in the emergency department, it's a 0.5. And so you can see here that these volumes are very small. Let's go to a 5 and a 9-year-old and just kind of take a quick peek down again and notice the danger. And I put that one in red, is at 0.05 for ketamine 101, and then 0.2 for the 10 and 1 for pain control. Here, the dose of morphine now here looks nice for the 2 and 1. It's 1 ml. That's a lot less kind of risky of a dose, I would say. But again, look up here. We're at 5 years of age, and we're still using under 1 ml, and in some cases under 0.1 ml for all these dosages. 9-year-old, we're finally getting 1.2 ml here, 0.6. Again, Dilaudid is still very small. The ketamine, it's still, I mean, this is just absurdly low. And then the morphine is starting to creep up a little bit, and a little bit more appropriate here. And then let's look at the adult. And again, here we have fentanyl finally maxes out at 2. V is nice. Dilaudid is still using a 1 cc syringe. So this is a worrisome one for me, I must say. Ketamine for pain is still only 0.19, and here for a full 100-kilo guy or gal, it's 0.25. Whereas the sedation dose, again, the IM dose, that's nice because the dose is so much higher that it's a lot easier to give. So that was kind of what I wanted to show you there. What I did want to show you that's kind of new. Some of you have seen this already, that map, but we added something in for this to kind of make things a little bit more user friendly, and it actually may not be on this version of it, but I wanted to show you where it's going to be. So let's say you start a new patient, and the reason I picked North Memorial is because they use ketamine, and I want to show you what one of their books looks like. So let's go to a six-month-old. Click on 6-month-old here, and then let's take a look what they have currently at their department. And so fentanyl, you can see, is 0.32. And so what we've done to try and make things a little bit more user-friendly is that if I click on the fentanyl, currently it doesn't show it on this particular app, but we've added a box here that's again as soon as we update this app for them, there's a box here that's going to show up, and there's instructions that you, not me, that you put in for your providers that will say something to the effect of add 9 mLs or add 1 ml of normal saline using a 3-way stopcock, so that it gives instructions prior to administration that's customized by you for your department. And so that box will end up going here. So let me just say given on that one. And then let's go down a little bit. Look at the ketamine here. So they have ketamine for analgesia, 0.02, ketamine for intubation, 0.16, and then ketamine for sedation. Now notice that, like a typical EMS agency, they carry all the 101, and again, these dosages are very small. So what do you tell your folks? Again, this is something that we need to talk about, and something that when you click on, let's say this one, the 0.02 ml, there'll be the box here that again gives very specific instructions from the medical director saying this is how I want you to do it. So, and then going down a little further, again, this is a customized item, so this is exactly what they would use at their department. They also, by the way, have a ketamine drip, and so for those of you who are critical care agencies, fentanyl drip, we didn't really talk about this only because it's really an EMS talk, and there aren't really that many critical care agencies out there, but all the critical care agencies and the flight agencies who use our system all have some formulation of the drip, which are really nice because you could see that they're customized drips for that age group, and they essentially do that. They essentially have drip rates that are normal, that are easy to follow and easy to use. So let's say ketamine drip, and tells you how to give it, and you can just give it. While I have you on the app, I wanted to show you something that we just added in. So all those patients, for example, you would just add your medical record number here. So we just type that in real quick. I'm just going to say 123. And then we make you verify that number. So this is whatever medical record number you use for your system. And then you open the patient record, and you can see here that it shows exactly what we gave. You would put in your name. I put Jim's name in there, and I'll say, okay, this is all accurate. And then what I'll do now is I'm going to submit it to my EMR and close. And this, technically, if we're connected into your ePCR, will then show up in the sequence of your ePCR. But what we've done in the meantime, you can go to the chart archive, and that's the chart we just did. I open it up, and I say I want to email it to either an email address, or I can fax it to, let's say, the hospital that I'm at. So I'm going to email it here to the doc. Now that email is sent as a PDF. It shows up on your desktop, or it shows up in your fax machine. And so that's kind of another way we're trying to improve the documentation that occurs in the field. So thanks for letting me show you that. Let me get back to this. And we're nearing the end. So what I'd like to do is, let's see. Sorry. What I'd like to do is open it up in a little bit for those, because I really want to hear your comments on this. But what I would recommend is to do the following. Pick a drug. for your agency or drugs, pick a dose, and forget about the range thing, right? So if you system, we force you into a number, so that there is no kind of question. I know people like ranges, but we kind of don't when it comes to this. Then decide on how to administer it, whether you're going to do it IV, IM, IN, or all of those. And then how are you going to dilute it? And once you've determined this and you have a policy, or maybe not a policy is not the right word, but a way of doing this, then you go and you start training with, you open the book and you say, okay, 4-month-old, 6-month-old, and then go to between a 1 and a 13-year-old and get the muscle memory going, and maybe get the discussion going, and people say, my God, what do I do with 0.04 mLs? And watch how many people will draw 0.4 instead of 0.04. And that's how we're going to learn about how to fix this problem here, because I really don't know the answers. And then, of course, train with the on your adult population as well. So I really thank you guys for staying on the call with me. But I really want to open it up here to those of you. I pretty much know everyone on the call, and I really would like to hear your comments and thoughts on these concepts, and perhaps we can start to move together to work towards a better understanding of pain control in pediatrics, because I don't think that people just get it all the way because of all the detail here. So you know what, I'll wait for you guys to raise a hand or to just type in a question, and I'll go from there. So if you don't want your voice to be heard, just raise your hand, and I'll open it up so we can hear your microphone. All right. Well, as I wait for people to do that, you guys all have my email address, peter@antevy.com. If you're going to be in Dallas, please stop me in Dallas, and we'll talk more. Email me, and let us continue along this path. This webinar, hopefully it was helpful, and again, I'm hoping to learn just as much from you as you are from me. Keith, awesome. You can unmute yourself, because I think you unmuted yourself earlier. You muted yourself earlier, so I can hear you. Yeah,
Peter,
you're on.
This is very helpful. You need to do more presentations like this, and talk about these the down and dirty how-tos, because when you were here with our medics and they learned how to use the 3-way stopcock and how to do that, those are the little things that make the difference, because you're right, when they're looking at these small volumes, they become more fearful of making a mistake, and so how to show them how to do this. And you're absolutely right. One of the best things that we did with our pain protocol was we got rid of ranges. And so the dose for morphine is 0.1 per kilo. The dose of fentanyl is 1 mic per kilo IV or 2 mics per kilo IN. And now the question has been, what should be the repeat? What's a reasonable repeat dose? And some of my medics have questioned, should I just routinely add Zofran for nausea? And of course, there's some sedative effect to the Zofran, and does that reduce the patient's pain and anxiety? So I don't know.
Interesting. Those are great comments. I think that the fentanyl probably has less side effects than morphine does. I routinely give Zofran for all my ketamine administrations. I've done that as a practice routinely. But those are the questions, Keith, that have to come forward, and I think that the only way that they'll come forward are in those training sessions we did. And I know we did the same thing for Peter up in Bend, who's on the call today. And I think that those are the items that I think moving forward, I would love to hear back from everybody and to say, hey, Pete, we did this, and these were the questions, and here are some solutions that we figured out, because I tend to agree with you that nobody talks about the nitty-gritty stuff, right? But in my opinion, that's where all the fun is. You know what I'm saying? It's funny. I put out yesterday randomly I put out a Antevy minute on how to make epi 1 to 100,000, and it was probably one of the most well received things, because very few people know how to use a three-way stopcock to make epi 1 to 100,000, and that's mind-boggling to me, but it's true, right? So thank you for those comments. I'm gonna open it up to Jim. You're on again.
Yeah, I was just going to ask you, Peter, about the syringe-to-syringe transfer device versus the three-way stopcock in terms of simplifying medication transference.
Yeah, so in other words, are you talking about the two-way versus the three-way?
Correct. Yeah, the TIE fighter is what some people call it.
What do they call it? What's the terminology?
We call it a TIE fighter because it sort of looks like an Imperial TIE fighter with the two little wings and then the
yes. Oh yes. And I think someone in Minnesota gave me one of those. They cost nothing, right? It may be, you. So my only comment on that is that when you have the three-way on there, there's a lot more that you can do with it, meaning that you can kind of keep it on, and you can you have a third place to attach it to, or you can use this to kind of do your waist. So if you saw the video I put out yesterday, I actually had the three-way on. I emptied the 9 cc's of Epi 1 to 10,000 first, and then I just turned it and I loaded it up, and then you can actually still use that third port. I'm going to bring in, actually, because Keith has been using the three-way. Keith, I'm going to unmute you again. What are your comments on the three-way, or if you have any experience with the TIE Fighter one? Keith, you have to unmute yourself.
There
you are.
It became very simple here. There's only one distributor of the TIE Fighter, and they want $1.35 each. Three-way stopcocks are about 15 cents. So
get out of here.
Wow. So that became
a lot less plastic too. That's so weird.
I know it, but there's only one maker, and so it's like, I'm not going to pay $1.39 for something that can be done for 15 cents. And I think the medics like the physical control of the three-way stopcock better, and not to mention the three-way stopcock has so many other uses when you're going to do a volume fusion. So the more you use it, the more you use it. So it's rather than having a one-off device that only has one indication.
Right. That's a great point. Personally, I have to agree with you on that one, and I'll tell Jim that I personally prefer the three-way stopcock as well, because I'm used to using it for push-pull in the ER. Where we're hooked up to the patient, and I turn, I pull from the bag, boom, I push into the patient, and I can get 20 per kilo in pretty quickly. I can get 60 per kilo in, within 30 minutes if I do it that way. So, okay, that's great. Anybody else who's on the call have any input on that, or any other comments before we say goodbye? Okay. All right, great, guys. You've been great. I love learning from you guys, and I think that we ought to continue these. And please email me, send me information. Oh, we have Nate Selstad raising his hand. Hold on one second. I'm going to get you on, Nate. 1 second. All right, hey, Nate, you're on.
Peter, I was trying to type, but that obviously isn't a skill. So the one concern I have with the three-way stopcock is I have known people who will take the more than the set amount of medication to be given. So they'll say, like, I have 2 milligrams of morphine and I'm only given 0.5, so I'm going to hook up. I'm going to put 5 in through and then flush it. So that's the only concern with three-way stopcocks that I see in my practice is people trying to freehand. So I think we need to be strictly aware of that.
You're right. That's actually a very interesting one. I think that the training there needs to be you only pull up what you need, right? And I think that's a good point. Just as a side note, the other beauty of the three-way stopcock is for adenosine use, right? So you see in this image here that the off would be down. It would be down, straight down, so everything would be open. The whole system would be open. and let's say this was your adenosine, this was your flush, and you can just go boom, boom, right from the hub, right from there. And what our setup is in EMS for the tubing is that you have a port here and then you have a port higher up, and all the medics are trying to give adenosine. They end up kind of pinching one side of the IV tubing down. It becomes this big cluster. And then once you teach them how to give adenosine using a three-way stopcock, boy, it makes things a whole lot better. So, but that's actually a great point regarding that. So, I think we have some work to do in this realm as far as learning more. Number one, getting more experience and hearing back from the people who are doing it, and then maybe starting to put together some educational practices that should be standard moving forward. So, awesome. Thanks for commentary, Eddie, and again, please send me any other information and any feedback on the webinar as well, and we're going to post this on our site for everyone to listen to if they want to. So I got to catch a plane to Dallas, and I appreciate all of you, and again, great to have friendship with all of you, and I appreciate it. I'll speak to you guys shortly. All right, bye everybody.